Good afternoon, everyone. I'm Neil Love from Research to Practice, and welcome to What I Tell My Patients. As today in our final program here at the ONS meeting, we're going to talk about the management of prostate cancer. We have a great faculty today, and we'll be hearing some cases from their practices and talking about some of the new developments in clinical research, including some things that just happened this morning in Chicago we're going to talk to you about. Very exciting. This has been quite a journey. This is our 15th year at the ONS meeting. And what we like to do each year is, first of all, provide a little bit of a research update in terms of what's going on in oncology, so you can really translate that for your patients, particularly new treatments that are coming along. And we're going to talk a lot also about patient education in those situations, particularly individualizing how you work with patients based on who they are. We like to say, what was different about this patient to take care of than another person with the same oncology situation, but a different person, different attitude, different value system, comorbidities, et cetera, et cetera, et cetera. You'll see that as our nurse practitioners on the faculty present cases. We also like to talk, and one of the reasons we present real cases is to really get a little bit of a flavor of the relationship that you have with patients and their families, and how grateful they are, going beyond the anti-cancer therapies that you provide for that relationship, and also to take a breath every year and just say, good job. What you all do is highly, highly valued by patients and their families, and great work. So with that, we're going to move on now and get into the guts of our program here. We like to start by introducing the faculty and just to lighten things up a little bit, and also put in a message of, hey, it's good to get away from your job every now and then. So we're going to start out by asking what the faculty likes to do to have fun and get away from things. So Neeraj, tell us.
30 seconds, you said.
Yeah. Right.
So one of the biggest attractions of being in Salt Lake City, Utah is you have one of the best hiking trails, slopes within 15 minutes or 20 minutes of your home. So my favorite pastime is to get away and spend time in the middle of nature, if you will, with family, of course. Thank you.
Awesome. Sandy?
Outside of work, I love watching movies. That's definitely something that I like to do. Somebody told me that my husband is really lucky because two things that I find really relaxing is cooking and cleaning, either which he enjoys.
So, Susan?
Yeah, so I like music. I like all kinds of music and seeing live music whenever I can, and I sing in a community choral group, so every Wednesday I'm practicing, and that's a great release. I also love to be in the garden, and I also like to cook. I mean, that's like, I come home from work, I like to chop vegetables. It's a good thing.
So actually, we were out in your neck of the woods last year for ONS, and they had the Coachella Festival. I don't know if you ever go to that, but I always viewed what we did as the oncology version of Coachella, because these are the artists. It's really an honor to really work with we brought about 43 people, investigators here, nurses and physicians, and it's just great to be able to work with you all. So anyhow, Kathy?
Yes to hiking. I live outside of Pasadena, California, so we have some great hiking there. I love movies, I love music, and I'm a tennis player and trying my hand at pickleball.
Pickleball, huh? There you
Cool.
go. I like that. All right. So here's our agenda for today. We're going to talk a little bit about an overview of prostate cancer. Then we're going to talk about an important trend that's going on in the management of prostate cancer. And really, you see the same thing we were talking Wednesday night in breast cancer, the intensification of hormonal therapy. So we know that in prostate cancer, androgen deprivation is often a key part of therapy. But what we're seeing now is more than just androgen deprivation, adding one novel androgen receptor targeted agents, and we'll talk about that. Then we'll talk about metastatic disease, particularly so-called hormone-sensitive metastatic disease, because there's been a lot that's changed in terms of clinical trials. We've already talked quite a bit about PARP inhibitors. Yesterday, we talked about ovarian cancer, where really PARP inhibitors were really initially brought in earlier, and then we saw that in breast cancer. We saw it also pancreatic cancer, and definitely in prostate cancer. One of the themes that we get into this week is really oncology strategy. How does the medical oncologist take information from clinical trials that are being presented, FDA approvals, guidelines, and sit down with a patient who has their own individual characteristics and come up with a treatment plan for that. And we're going to talk about an FDA approval that occurred yesterday that related to PARP inhibitors. It was very interesting. And finally, we'll talk about a form of therapy that really has been pioneered in prostate cancer. We'll see whether it comes into other cancers, radioligand therapy, and so particularly the agent lutetium. So just to start with a little bit, we're going to get into this case in a second of Kathy's, of a man who presented with high-risk prostate cancer, and he's a good example of this idea of intensification. But this morning at 9:30 in Chicago, there was a big presentation that everybody in prostate cancer was waiting to see. This was a plenary presentation at the American Urologic Association. We're actually going there tomorrow to do 2 programs, but this was presented here today. Everybody was looking forward to it. And the faculty, because it was 9:30 this morning, they're here, they didn't see the data. So our team had printed it out and just showed it to them. So I got to see them I asked them to predict what they thought they were going to see. So before we get into this case, I just got to ask you, starting with Neeraj, this is a study, a randomized phase 3 study looking at hormonal therapy in patients with so-called M0 recurrence. So they've had local therapy to the prostate, either radiation therapy or surgery, radical prostatectomy. And then because of the fact that you all have this marker that everybody wishes they had, which is PSA, the first indication of relapse is that the PSA goes up before usually you see anything on imaging. We've been using hormonal therapy forever in that situation, yet I don't think we've ever had a phase 3 trial even looking at this until today, until this morning. I asked you to predict what you thought we were going to see, and actually you were pretty close to predict what you see, which is by intensifying hormonal therapy, you got an extra bump. So we know when you give androgen deprivation that the PSA is going to go down. Everybody's been doing that forever. But the question is, what about instead of just giving androgen deprivation, cutting off the testosterone, accessibility to the tumor, what about if you added on another agent, anti-androgen or abiraterone? We've been seeing all throughout the spectrum of prostate cancer, when you do that, just like in breast cancer, you add CDK, for example, to hormonal therapy, you get a greater effect. We've been seeing this, Neeraj, but today we saw it in the M0 situation. First of all, can you explain a little bit more about sort of the usual path that a patient with prostate cancer takes and when they present and then develop relapse? And we'll talk more about it later, but I just got to ask you right now, what do you think about this study? I think it's going to completely change practice, but what are your thoughts?
So definitely these results from the EMBARK trial, the first phase 3 trial of this magnitude happening in patients who have PSA relapse after local therapy. So whether it got prostate radiotherapy or radical prostatectomy, PSA comes back. And now at this point of time, the standard of care is intermittent androgen deprivation therapy for these patients. This trial asked the question of adding enzalutamide to androgen deprivation therapy, so deeper androgen blockade, versus androgen deprivation therapy in this patient population. One very intriguing and novel aspect of this trial was they had a third arm of only enzalutamide compared to androgen deprivation therapy alone. And I think this is for the first time this kind of experiment has been done at such a big level, at such a high level, at such a large level, in a large phase 3 trial. And what is intriguing is that, yes, enzalutamide plus androgen deprivation therapy was superior to ADT alone. We all expected that. But enzalutamide alone was also superior to androgen deprivation therapy alone. So I think this will create another line of thought process. What we have practiced in our clinic for a long time in patients who have hard time tolerating ADT, and we have always talked about, or on an anecdotal basis, we have used enzalutamide alone, or apalutamide alone, or even bicalutamide alone. But I think for the first time, Neil, we have the evidence, level 1 evidence to support that approach.
Yeah, I was shocked. I didn't even know, Sandy, that enzalutamide works without androgen deprivation. You expect these men would be, feeling much better than being on androgen deprivation. I imagine your phones are going to be ringing off the hook Monday morning with your prostate cancer patients about this. I would imagine people are going to ask themselves in this situation, do I really need to take androgen deprivation? It looks like the best choice would be take androgen deprivation and enzalutamide, but it seems like maybe for men and we'll talk particularly with the nurses about what comes with androgen deprivation. This is not an easy therapy, and it kind of is the prostate cancer equivalent of what we talked about the other night with ovarian suppression. A lot of the symptoms are even in breast cancer in women, and a lot of these symptoms are similar. Sandy, and actually we just printed out the slides so we can give it to everybody. We were just looking at it just now because it was just presented. You guys can take a look at it. Any thoughts about how people are going to react to this, Sandy?
Well, one thing that I would add to what Neeraj just said was, for this group of patients, their life expectancy, if you think about, it's going to be measured in decades. So people with biochemical recurrence can live for a long time. So to show a trial, all of our trials, we like to show that people are living longer. To demonstrate an overall survival in this patient population would take years and years. So this trial looked at what does it take to develop metastasis, and that's what the benefit is, that by combining ADT with enzalutamide is superior compared to enza alone. The interesting thing that they also did was, we know prostate cancer is so heterogeneous. There are people who can live for decades, and then we also know that there are some men who develop metastasis and die from that disease rapidly. So they looked at PSA doubling time and picked those patients who are at a higher risk for developing metastasis. So I think they really enriched their patient population, which makes this trial even more meaningful in today's practice.
Do you think, Sandy, you're just looking at the actual data right now yourself for the first time, and so, of course, you'll have to study it, talk to your colleagues, but what do you think the clinical outcome of this is going to be, Sandy? Do you think there are going to be men who may choose to go on enzalutamide without ADT? Do you think that people are going to generally, for younger people who, they want every possible benefit, they're going to go for ADT, the whole deal, ADT plus enzalutamide? How do you think, and then all variations in between, any predictions how people are going to respond to this?
I think it's a great choice because there is patient anxiety related to seeing that PSA go up. So I think you're right, Neil. There's going to be some patients who are young who want to be aggressive and they want to get the maximum benefit, especially for us where I'm at. People come in with this data, I'm sure, on Monday, with this paper saying that there is this benefit of combination, versus others who are not very anxious to go on all medications and would rather take a pill compared to both. So I think it's great to have these options. Patients in the past, we have done these treatments intermittently. This is sort of committing to the combination for a while. We'll have to sort of play through this and see how patients tolerate and where this will take us.
All right, well, let's jump into the cases. I'm sorry we're all excited because we just, don't usually have this happen. And, actually we're doing a program in Chicago tomorrow night on prostate cancer. We're going to be able to actually ask a bunch of docs what they think about this. When you come into work on Monday, ask your docs, did you hear about the EMBARK study at the AUA meeting? Because this is going to be one of the biggest studies in oncology this year. Well, just to sort of reinforce this concept of, increasing intensification of hormonal therapy, Kathy, you have a 72-year-old man. What happened with him?
He is a plumber, electrician type of gentleman, had a prostatectomy, and ultimately, very soon thereafter, we do a Decipher test, which is one of these tests that helps us look at patient information and predict how their likelihood of recurrence. So his came back very high, which we were more inclined to treat him more aggressively. So we wanted to start him on ADT, and unfortunately, around the time we were making all of these decisions, he ended up having a heart attack, got diagnosed with diabetes type 2, and he was also kind of actively pursuing pelvic floor rehab for some urinary incontinence. So when you think of this as a very rich nursing example of how do we help this gentleman manage all of these changes he's gone through and prioritize, right? So we tried to get him Relugolix, which is a newer oral version of ADT, because we were trying to limit the number of times he came into clinic. Couldn't get it authorized right away, but we did eventually. And I think most of our visits after that were spent on, looking at him really globally as a person. Okay, what's going on with the heart? He had this MI, opted not to have his CABG, so he really needed cardiac rehab very much along with all these other things, which were highly complicated.
So before I ask Neeraj to talk a little bit about sort of the strategy of hormonal therapy in prostate cancer, just to take a step back about clinically how this plays out, Susan, can you comment a little bit about some of the consequences when you remove testosterone from a man, and when you sit down and talk about whatever type, and we'll talk about the different types of ADT, androgen deprivation therapy, what are some, and this is like, some major things to be informing a patient about. What are some of the things you bring up initially?
Well, I mean, we're basically talking to them about no testosterone, and what goes along with that, what is often primarily important to people is a lack of erectile function, but also a loss of libido. Over time, they can develop bone density loss, they can gain weight, they're more likely to hold weight like in their soft tissue of their belly, like the sarcopenic weight gain as opposed to like overall. They can get hot flashes. For some men, they are like ridiculously debilitating. Other people call them warm flushes. And then over time, also the whole risk of developing cardiovascular disease, metabolic disorders, like including diabetes, hyperlipidemia. So they're really looking at a major change in their life. Now, there are some people that will, say, I don't care, I want to live, everything is, I don't care what I put up with. And there's others that are like, I cannot do this at all. I find it often more difficult for younger men. They have more joint issues sometimes and pain than people who are older. And if there's a way that they can have it limited, then they like that.
So yeah, and I'm really curious to see what happens after people see these data on using enzalutamide without ADT, because again, may not be the very most effective therapy, but maybe a lot less toxicity. Perhaps a man would choose to do that. We can really ask them. But Neeraj, can you talk a little bit about sort of the strategy of how ADT works? Also about this new agent, Relugolix, the difference between an antagonist and an agonist and how they work, and particularly about what we think, we're not sure whether or not by using a so-called antagonist like this oral agent, Relugolix, it's actually safer for men like this who have coronary artery disease.
Absolutely. So androgen deprivation therapy works by telling our brain, the pituitary, not to stimulate the testicles to make testosterone. Most of the ADTs we have been used over last 30, 40 years, ever since they were approved in 1980s and 90s, they work by stimulating, or they are GnRH agonists, so they stimulate the GnRH receptors on the pituitary, and this is irreversible binding with those receptors. So after initial stimulation, it leads to competitive inhibition. And that's how GnRH agonists like Leuprolide, Goserelin, and so many other drugs we have been used in the past have worked. A new category of drug, GnRH antagonist, came up in last 3, 4, 5 years. The first one to approve was Degarelix, which is monthly injection. And then second one, which was the most enticing aspect of the second one was, this is an oral pill. So this oral pill, Relugolix, got approved about 2 years ago based on the data from the HERO trial, which showed that patients who required these ADT injections who had biochemical recurrence or who had metastatic disease. They were randomized to relugolix, which is GnRH antagonist, so direct inhibitor of the GnRH receptors on the pituitary. When relugolix was compared with leuprolide, it was equally efficacious, but the most intriguing aspect of the trial results were that the patients who had a cardiovascular illness happening over the preceding 6 months, so somebody had a stroke or somebody had a heart attack, they were 5 times less likely to have another major cardiovascular event on relugolix than leuprolide. Similarly, patients who did not have any heart disease or heart incidents or cardiovascular incidents in preceding 6 months, if you look at all comers, relugolix use was associated with half the incidence of major cardiovascular events. So I think what was most interesting to me from this trial was not that relugolix was as efficacious as leuprolide. We all expected that. But what was striking was the cardiovascular safety data associated with relugolix.
And the other issue, and I think you heard a little bit about this in this case presentation that goes across oncology, is the issue of copays, particularly for newer, more expensive agents that are coming into practice on oral medications. So yesterday we were talking in the CL, chronic lymphocytic leukemia session. They all get great oral BTK inhibitors, venetoclax, and standard of care is first-line therapy with these agents. But you look nationally, and maybe a quarter of people in the United States don't get it. We're not sure why. Some people say it's because the docs don't know what's the right therapy, which I don't buy into. I think it's because it's hard to, get these paid for. Susan, anything you want to share about your experience with getting oral medications, the copays paid for, particularly relugolix, as in this case?
Right. Well, and actually, all of the new oral medications, apalutamide, abiraterone, enzalutamide, they cost a lot of money, and most people need copay assistance if they don't have an insurance plan that covers it. And that's also true for relugolix. I've had patients who are don't have secondary insurance and they're Medicare, and they are not able to get copay assistance, and they can't afford it because it's once they get out of their donut hole, it would cost them $7,000 a month or some such large number to be on this. I've had people who can get it through the company who provides it for them if they meet certain financial guidelines. But overall, I've had people who decide, I'm not going to pay this, go ahead and give me the injection. I actually had somebody who had been on intermittent therapy for years and with a cardiac history and had a stroke. And so, when relugolix became available, it was kind of like, this might be a better thing for you to use. And his first reaction was, I don't want to take another pill. So that was kind of surprising to me.
Before you comment, Sandy, another thing is, it's interesting because when you ask the CLL people or the prostate people, well, is this a problem getting these agents? And they go, oh no, my staff, they know how to get it, they know all the specific programs. But, general medical oncology situation, you're not just dealing with prostate cancer, you're dealing with tons of CLL and everything else. So I kind of wonder if part of this is really learning how to negotiate, how to actually get this covered for your patients. Neeraj?
Can I add one thing about relugolix? I think one of the best asset for this drug, in addition to it being oral versus IV, is for patients where we do hormonal therapy intermittently. We have done it with leuprolide and with relugolix. It takes a long time once you stop the LHRH agonist. It takes months, sometimes even years, for the testosterone to recover. The beauty about relugolix is its ability to recover testosterone much faster. And I think men who are off hormonal therapy really appreciate it when they see their hot flashes go away. They recover their testosterone faster. And to me, that's a great use, in addition to what Neeraj described about the cardiac patient.
Yeah, that's a really important point, and I'm kind of curious in terms of how it actually plays out in your practices in terms of, using these oral agents. Kathy, you put together this slide on some of the issues that you bring up to patients who are about to get ADT. I want you to go through that. But just to clarify what we're saying about intermittent hormonal therapy, this is a quality of life thing. We just we talked about the very difficult, and again, same thing in breast cancer, ovarian suppression, we talked about the other night, very difficult. And then with you intensify it, with aromatase inhibitor in breast cancer, even more problems. So one of the strategies that have been used is to use it intermittently. It seems, and I don't even know if I don't think anywhere else in oncology where they do that, where basically you treat the patient, the PSA goes away, and then the patient gets all the symptoms, then you stop the ADT and wait for the PSA to go back up. Then when it gets back up, you treat again and you push it back down. And the idea is hopefully when, as Sandy was saying, sometimes they can be off therapy for a long time, that hopefully they'll have a better quality of life. So Kathy, how does intermittent therapy play out? Do these men really get relief of their symptoms? And there's so many things to talk about. We could spend the whole hour about ADT, but what again are some of the key things you want to bring up in your first meeting when you bring this up to a man and his family?
Yeah, sure, thanks. One of my roles is I run a prostate cancer support group, and we talk about this a lot. I mean, a lot. And some of our guys call it manopause instead of menopause. It's life-changing for most people. Occasionally you'll find a guy that if we do intermittent treatment on them and you ask them how can they compare how they feel on versus off, and they say, it's okay. But you're right, Susan, there are men that really struggle, especially with hot flashes in particular. So side effect management, very helpful. We talk a lot about exercise, relaxation, nutrition. These guys need to really keep their muscles strong and their bones strong. The other thing I would talk about just briefly, because it's such a hot topic in nursing, is patient adherence if you're using an oral ADT. We talk about this a lot. I feel like men will tell us if they feel that they can manage an oral agent because I've heard, I could never take a pill. I'll be too tempted not to take it. Think about you have a pill in your hand and it's going to do all those things to you, right? So on the other hand, the convenience of pills, the fewer clinic office times, it's been a great option for our patients.
So I want to move on in a second, talk about metastatic disease. It's just so exciting to really think about what's going on right now, including literally right now. But Sandy, maybe you can just sort of summarize the concept of intensification of non-metastatic disease. So we're going to talk about metastatic disease. And you saw me flipping through the slides. You can go back and look at them later. But one of them was kind of the natural history. So Sandy, we're talking about everything before metastatic disease. Everything from high-risk prostatectomy, this Decipher assay, similar to Oncotype and Mammoprint that we were talking about the other night in breast cancer, identifying high risk, to post-prostatectomy recurrence, where usually radiation therapy is given locally, plus hormonal therapy now, all the way up to metastatic disease. Sandy, can you just talk a little bit about this concept of intensification of hormonal therapy, and particularly what it brings in terms of additional symptoms above and beyond what we've just been talking about with ADT?
Sure. I mean, I think this is a really important area because here the goal could be to have a higher cure rate, right? So once patients have metastatic disease, at least today in prostate cancer, we are not able to cure them, but we look at things that can improve longevity. But for this group of patients, we have an opportunity to improve cure rate. So what are the two treatment options? It's really been surgery with radical prostatectomy or radiation. And in both these areas, there are tools that allow us to detect disease earlier, to be able to predict who's at a higher risk. So for the people who are at low risk, this is a group that can be watched. But for people with high risk disease, you want to come in with aggressive treatment and you want to treat them so that we can achieve a higher fraction of cure. So for patients with surgery, typically hormonal therapy has not been used. But for patients with radiation, when they get radiation, over the last 3 decades, we have used androgen deprivation therapy. Now we have some data from the group up in the UK showing that for patients who are at high risk, adding abiraterone to ADT has resulted in increased outcomes, including cure. So I'm very excited about this group of patients because it's for a finite duration. So they give hormonal therapy for about 2 years with radiation, with the intent that there'll be a higher fraction of men who could be cured from this disease. Some of the tools that are used are imaging tools. So MRI is used quite a bit to sort of help determine risk. We use newer scans such as the PSMA PET imaging, which helps 2 things. It helps us identify who we should not be doing local therapy for, and it certainly now becomes standard, and it's in NCCN guidelines for patients with localized high-risk disease to get PET imaging. And then what Kathy mentioned was the Decipher score, which helps us not treat all patients equally, but this is looking at their genomic data to help predict and put people into different buckets as to what their risk is. And I think the field where it is today is for patients. Right now, everybody who's getting radiation gets ADT, and then people with high risk, we do ADT plus abiraterone. I think the future is, could we tailor it? So for people who don't need hormonal therapy, we want to give them a shorter course or maybe none. And for people who are at a high risk, we want to intensify it so that we maximize on the opportunity of cure.
You know, it's really amazing how many huge trials have come out in the last 5, maybe 8 years in prostate cancer. Before then, we had very little. We were treating, based on historical series. Neeraj, one of the things that we saw in the earlier stage disease that really helped get answers quickly, as Sandy was alluding to, is figuring out who the people were at higher risk. And one of the key factors, and it makes a lot of sense, is when you look at the PSA doubling time. You remember, you're seeing that. You shouldn't see any PSA. Only place that comes from is the prostate. If you've had your prostate taken out, you shouldn't have any PSA. So you know that the disease is back. You don't see it. But one of the things you can look at is the doubling time. So if a man comes in and now he has a PSA, and then 3 months later he comes back and it's doubled. 3 months after that, it's doubled. So he has a doubling time of 3 months. Other men might have a doubling time of 2 years. And it makes sense, if this is an indirect reflection of tumor growth, that if you pick patients who have high doubling times, which is what they did in the study, and what they did in this study that was just reported today, you're going to see the results quicker because these patients are at greater risk. Another thing that Sandy talked about, Neeraj, that really has changed the whole way we look at prostate cancer are these PSMA scans. Can you explain what they are? Because the bottom line is they're picking up metastases that we could not pick up previously. So all the studies that we've been doing a lot of the studies didn't use these scans. Now we have them. So there are people who would have gone in a study where there wasn't, assuming they did not have metastatic disease. Today we do a PSMA scan and we see the metastasis, and it really kind of creates a conundrum. Can you talk a little bit about, Neeraj, about how this affects clinical decision-making, the PSMA scanning?
Of course. So first of all, if you want to criticize these beautiful data which were presented this morning in AUA, you can always say, is it possible that some of these patients who are really benefiting had indeed metastatic disease which were not picked up by the CT scan and bone scans, right? These are high-risk prostate cancer patients, PSA doubling time of less than 6 months or 9 months. So in this context, the advent of PET scan or PSMA PET scan has really changed the overall diagnostic and treatment landscape, if you will. The way we used to practice, the way we used to diagnose these patients has literally changed. So PSMA PET scan is a lot more sensitive than traditional CT and bone scan. And a study in actually GU ASCO just a few months ago showed that up to 15 to 20% patients who were diagnosed to have localized prostate cancer and who were going for surgery indeed had metastatic prostate cancer based on PSMA PET scan. And in these patients, if you could go back and do the PSMA PET scan, which happened in this study, but in general for all our patients who have this localized high risk or localized disease with high risk features, and if you do PSMA PET scan, up to 20% patients will unfortunately have the diagnosis of metastatic disease, but at least will be saved from the chronic morbidity and mortality of surgery or radiation. So from that perspective, PSMA scan is going to be changing the way we are approaching these patients with localized prostate cancer.
All right, well, let's go back into another case. You know, we talk about the trials, we talk about the disease, and then there's real life. And it's never as straightforward when you start getting into patients. I think all these patients we're talking about today, most of the patients we talk about this week, you know, that's the way it is. You know, you have this theoretical idea, you know, put up an idea of a case, but when you get down to a patient, it often is different. So Susan, you have a 90-year-old man who's on enzalutamide. What happened with him?
He's castrate sensitive.
Right.
Yeah, he doesn't have metastatic disease. So
Right.
he's a guy who is still actively working. He had been on intermittent hormonal therapy for biochemical recurrence, and then he became castrate resistant. And so we were planning to start him on enzalutamide, which we did.
Just to clarify, though, so he doesn't have metastatic disease, he just
Right.
has PSA, but he's progressing on androgen deprivation, because up to now, that's kind of what the first therapy, up until today, that's the first therapy. Starting tomorrow, I'm not sure, but anyhow, he got the usual.
So, but when we did start him, we didn't have the availability
Right,
of
of course.
PSMA PET scans also, because one thought now is, you know, if somebody becomes castrate resistant and you get a PSMA PET scan and there's one tiny spot someplace on a bone or a lymph node, you may be able to delay adding additional therapy if you can maybe radiate that spot. And I mean, that's also true in people who didn't have metastatic disease
Yeah, that's a
before,
good
if you
point.
want to postpone androgen deprivation therapy. I mean, in this case, this man, I had concerns because he already had osteoporosis before he even went on androgen deprivation. He had hypertension, which you always didn't pay attention to. Sometimes he traveled between Pennsylvania and Florida back and forth. And so sometimes he'd let his prescriptions run out and not pay attention to it. So when we were planning on starting him on enzalutamide, I had to kind of keep that in mind and say, how are we going to ensure, number one, that you stay on your hypertensive meds, and number two, that you're going to report to me if you have issues? Like the major side effects I think about with enzalutamide that I educate my patients about is that it can cause fatigue, it could cause dizziness. There's a higher risk of falls and fractures in people who are on enzalutamide. So in his case, I wanted to make sure that, and hypertension can be accentuated as well. So I wanted to make sure that he was managing his hypertension, that he had a way that he was going to communicate with us if he was tired or if he had anything else going on. And I wanted to avoid at all costs him having falls since he was osteoporotic. And all the ramifications for that for a 90-year-old having a fracture.
So, Neeraj, can you talk a little bit? We talked about intensifying hormonal therapy, adding in something beyond ADT. Basically, we're talking about the agent abiraterone, which comes with prednisone, as well as several androgen receptor pathway inhibitors. Enzalutamide is one, darolutamide is another one, apalutamide is another one. These are used when endocrine therapy is being intensified, whether it's M0, we're going to talk about in the metastatic setting. But can you kind of talk a little bit about the difference between how Neeraj abiraterone works versus the androgen receptor pathway inhibitors, and what you see in terms of side effects, and in particular with the three pathway inhibitors that you see very similar data, what difference you see in terms of tolerability?
Abiraterone works by stopping an enzyme inside the prostate cancer cells. This enzyme, CYP17 hydroxylase, allows prostate cancer to make its own testosterone. So although we have stopped the testicles from making testosterone by using these injections or relugolix, but then if that CYP17 hydroxylase can allow prostate cancer to make its testosterone, then that whole process can be circumvented by this new mechanism. So abiraterone stops the CYP17 enzyme, and works by stopping the intratumoral production of testosterone. Recent data have also suggested that one of the metabolites of abiraterone, it's a complicated name, I won't get into that, but one of the metabolites of abiraterone also blocks androgen receptor. Now, the problem with blocking that enzyme system is also associated with making corticosteroids. We all need them. So we have to supplement corticosteroids when we use abiraterone in these patients. And the problem is there is no one dose, so we have to use 10 milligram prednisone with abiraterone, which basically means these patients are on prednisone 10 milligram for a long time. Now, it's different when patients have post-chemotherapy metastatic castrate-resistant prostate cancer, and they are going to be on abiraterone for, say, 10 months. But it's a very different thing to be on abiraterone for 3 years or even 5 years. And that's where challenge comes. Chronic prednisone use can cause osteoporosis, hypertension, and there are many associated problems with abiraterone, such as congestive heart failure, cardiovascular disease, and so on. And of course, diabetes can get uncontrolled with long-term prednisone use. We do not see these problems with these AR blockers, such as enzalutamide, apalutamide, or darolutamide. We think darolutamide is maybe better tolerable than enzalutamide and apalutamide because it doesn't penetrate blood-brain barrier as avidly as enzalutamide and apalutamide. Having said that, there has not been a single randomized control trial comparing the effectiveness and tolerability of darolutamide with apalutamide or enzalutamide. So I always say that we think that one of these drugs may be more tolerated than the other drug, but among these three drugs, I think they are all equally good, very efficacious, and they can be used in our patients with metastatic CRPC or metastatic hormone-sensitive prostate cancer.
So, Susan, any thoughts about that? You know, again, we talk all week long about the challenge of comparing two different trials. You know, what you really want is to compare two things together, but you have to indirectly compare. For example, we mentioned 3 of these androgen receptor blockers. You have to compare indirectly, and you can't really do that. But you can also ask clinicians what their experience is. Of course, now you're talking about a lot less patients, but you ask people, they all have their opinions. So I'm going to ask you, Susan, what are your thoughts, particularly in terms of tolerability? I mean, I think we see the issue of abiraterone versus the anti-androgens. Well, but what about these 3 anti-androgens? What are the side effects you see, and do you think you see a difference in them?
Sure. Well, I mean, I tend to see less fatigue with abiraterone and prednisone than I do with the other agents. But that said, most of the time these things can be approached with a dose adjustment, and people still get responses. I really am thinking a lot about what the patient's comorbid diseases are. So if somebody is diabetic and you want to stay away from adding in prednisone, then I'm going to go for one of the other agents. If somebody has a history of seizures or, CNS disruption in some way, or if they had like a stroke in a short period of time before they were going on the medication, I would stay away from those that cross the blood-brain barrier, and then I would maybe think about something like darolutamide. So those are the kind of things that I think about. The other thing that is really important is the way that they're given. That is important in teaching because, first of all, example, abiraterone has to be on a totally empty stomach 2 hours after a meal, and you have to wait an hour before you eat. Whereas you want them to take the prednisone with food so it doesn't bother their GI tract. They're also, the dose is 4 pills. It's important in that particular situation and with other ones that are once-a-day drugs that they take them all at the same time. Enzalutamide is 4 pills all at once. Apalutamide, however, is 2 twice a day. It's important that people recognize that they have to take them all at once. And the other thing to think about is, can they swallow pills? Enzalutamide, now it comes in tablets, but it's very large tablet. And if somebody has trouble swallowing, they can't dissolve it, they can't do anything like that. So you have to, a lot of patient-specific factors that you have to think about before you start these
You know, the good thing is what Neeraj said, which is in terms of efficacy, there's really no difference between the three. So you're really just trying to find the drug that's going to be best tolerated. 90-year-old man getting enzalutamide sounds like interesting. Did he have any issues with tiredness or
He
CNS
did.
thing?
He did. Within the first couple months of treatment, he did become much more fatigued, and so we reduced his dose to half dose. His PSA had gone down to nothing. And then when we evaluated him again, he actually was still a little tired, not sure. It's hard. Sometimes it's hard to tease out what this fatigue is based on, the patient's age and what their activity level is and what they're doing. Like he's running back and forth between two states and doing a lot of other activities. But ultimately, we ended up dropping him down to 1 pill a day, and it has maintained him for a few more years.
So curious, Kathy, what your take is on these agents, and also specifically apalutamide. There are patients that get a rash with apalutamide, I think the minority, but I'm just kind of curious from your point of view, and when you look at these three agents, how do you think through which one matches up best with which patient?
Yeah, that one in particular seems to be very, very tolerable, but we've seen some pretty dramatic rashes, one this week, as a matter of fact. And rashes are something new for guys that are going through this type of treatment for the most part. So when they get these new things, those phone calls are really frantic. They're like, I have this, and what do we do? So we hold, and we're lucky to work in a big place with dermatology right next door. And so we make sure it's okay to restart at some point anyway. But it's, some of these side effects are a little bit unusual for our prostate group. So getting more knowledgeable about things like that, derm, has been interesting.
Neeraj, any comments, again, also in trying to match up the right drug with the right patient?
Just want to add to what Kathy said regarding rash. Most of these patients will not have recurrence of the rash once we stop the drug and restart after 7 days. They're pretty self-limiting rash, except very small number of patients, maybe 1%, who may require some kind of ointment, such as a mild steroidal ointment for maybe 3-4 days. This is quite well tolerated.
In your mind, Neeraj, how would you compare tolerability of enzalutamide and apalutamide?
It's hard to tell a difference. Yeah.
How about darolutamide? Is it hard to tell the difference between the three?
I really hesitate in talking about difference in tolerability based on anecdotal experiences, because as Kathy said, it's so nice to see we have arrived at a point where a 90-year-old man can be treated with anti-cancer therapy. And that speaks volumes about the overall tolerability of these drugs, whether it is Enza or APA or darolutamide.
So here's the press release we just saw, but when I saw that, I didn't realize when I saw this press release how momentous this was going to be. This is really going to be interesting to see what happens over the next couple of months. Let's talk a little bit about metastatic disease, and particularly so-called hormone-sensitive metastatic disease. So we're talking about patients who have not had previous androgen deprivation therapy. There's some men who never get a PSA and they walk in the door and they have metastatic disease. Of course, they've never had prior ADT, but they have METs. On the other scenarios, they've had local therapy, radiation, or prostatectomy, and then at some point after that, they may have gone through an M0 situation, but at some point after that, they develop metastatic disease. So it's been a real conundrum about how to manage these patients. This is a study that was presented, I think it was last year, combining what we just talked about, which is ADT plus an anti-androgen. In this case, it was darolutamide. But then on top of that, they added docetaxel. And before we hear about this case that Susan has of a 76-year-old man, and his case is a little complicated, but he has metastatic disease. Sandy, can you kind of paint a little bit of a picture about what we've learned, particularly about this so-called Arasens regimen that was just presented with this triplet approach, and about the management of these patients with hormone-sensitive metastatic disease, and right now in general how you and other investigators in prostate cancer are thinking through how to treat these patients?
Okay, sure. Metastatic prostate cancer, really, in the last decade, so many changes that have happened. You know, really, when patients come in, it used to be so straightforward. We would just put them on ADT, and that would be it. But now things have changed in this last decade. We think about patients like Dr. Love said, we think about, is it de novo? Did they just come in, never had a PSA, come into the emergency room, have back pain, and a PSA of 600 and widespread Mets? That patient is extremely different from the patient who's had a prostatectomy 7 years ago, then has a slow rise in PSA, and eventually develops metastatic disease. We also think about volume of disease. Does the patient have 3 bone mets versus 20 bone mets? So we think about high volume versus low volume. So all of these come into our treatment decision when we are seeing this patient in front of us. So that's the patient characteristics. And then we think about the drugs themselves. We have had 9 randomized trials, probably including about 10,000 men total, telling us that ADT alone is not adequate in taking care of patients with metastatic disease. We need to do ADT plus something else. And earlier it used to be just ADT plus chemotherapy with docetaxel was superior to ADT alone. So that was the beginning of this whole cascade of trials that we saw in this disease space. So chemotherapy became embraced as being used along with ADT. Then came along some of these other novel drugs. So the first of those were ADT plus abiraterone. That was superior to ADT alone. So now suddenly we had a choice. We could give people either ADT plus chemo, or we could do ADT plus Abi, and you had the choice of IV versus oral. And after that came a cascade of studies again, looking at ADT plus apalutamide was superior to ADT, ADT plus enzalutamide was superior to ADT. So the same choices that we've been talking up till now applies to hormone-sensitive disease. Just as we were getting used to this doublet, a concept of triplet was introduced into the scene, where now people were combining ADT plus chemotherapy, and adding either abiraterone or darolutamide appeared to be superior than just ADT plus chemotherapy. So we have to wrap this concept of who's appropriate for triplet therapy. We think that overall not everybody can get all these treatments, right? So you're seeing this 90-year-old. It's not practical to give this 90-year-old ADT, chemotherapy, and any of these drugs. So we sort of have to pick about the patient in front of you, but I think essentially the field is moving towards patients with de novo disease. Clearly, they have a worse outcome, and de novo with high volume, particularly, have even a worse outcome compared to that patient with localized disease who has 1 or 2 mets. So if I see a patient today who has de novo disease with high volume and who's young, fit, motivated, I think that patient is definitely a candidate for triplet therapy. Otherwise, I think most people, a doublet with ADT with one of these drugs, you have a choice, take a pick, I think would be a good choice.
So I know a lot of you are attending many, if not all, of our meetings, and I feel like every one of these, I'm saying there's so much going on here. This is just a tasting menu. I think it becomes obvious as we start to talk about, we got a bunch of other things we haven't even got to today, but we're hopefully, this is something hopefully will stimulate your interest to learn more. In terms of how fast things are moving, Neeraj, I was just kind of reflecting back at the beginning of the pandemic where things were with this situation was you were choosing between giving docetaxel or a second hormonal therapy. That's where we were at the beginning of the pandemic, because then at that point when the pandemic came in, people pushed away from chemotherapy because you didn't want to bring people in if you could give them a pill. Now, 3 years later, we have another study looking at a triplet. Neeraj, can you talk? We're going to hear about this patient in a second who, as always, when you get into real life, it's a lot more complicated. But maybe you could just reflect back on what it seems for me from talking to you all is the current paradigm for this situation, which is the possibility of a triplet which is usually given in younger patients who can handle chemotherapy, want every possible benefit, particularly if they have a lot of disease, as opposed to, like, say, an older patient who you maybe don't want to give chemotherapy to, particularly if they don't have that much disease. But Neeraj, how does it actually play out in your practice now that we have the triplet concept out there? Are you kind of looking first and seeing, can they deal with chemotherapy?
Yes, great question. I always start by telling patients about the data, what we have. And what Sandy beautifully described, the evolution of treatment landscape in metastatic hormone-sensitive prostate cancer, I'd like to add to that triplet therapy regimen was compared with ADT plus docetaxel chemotherapy. It was not compared with ADT plus a novel hormonal therapy, such as ADT plus darolutamide or abiraterone or apalutamide. And that is a problem, because we do not know if the triplet is better than ADT plus a doublet of apalutamide or enzalutamide. So what I do is, and then I would like to add from the real-world data, in 2021 or 2020, that was 5 years after docetaxel was endorsed by all guidelines as the standard chemotherapy regimen in combination with ADT for these patients with new metastatic prostate cancer, only 7% patients in the US received docetaxel for that setting. And that tells me something which is really happening in the real world setting, where patients are not really, may not be perceived healthy enough, or they may not be enthusiastic enough to get chemotherapy. So what I practice in how I practice in my clinic, everybody is a candidate for ADT plus a novel hormonal therapy. There is no doubt about it. Unless they have a life expectancy of less than 2 years, I offer them that therapy. On top of that, I look at some bad players, genomic players inside the tumor, P10 loss, RB loss, P53 loss. So those are the complicated genomic markers. If I see many of them, I tend to push for docetaxel triplet. If I see liver metastasis, I tend to push for docetaxel triplet. But I usually go with ADT plus one of the novel hormonal therapy as a standard tool for these patients.
You know, if you think about it from the point of view of quality of life, you're sitting down with a man and about to explain, we're going to recommend androgen deprivation therapy and all that brings with it, this gigantic life change. And now on top of that, also we're going to give you chemotherapy. So you can understand why a lot of people are hesitant to use that. I want to move on in a second and talk about another major development in the field. The use of PARP inhibitors really looks like maybe going to be as important as it is. Yesterday we were talking about ovarian cancer. But Susan, can you tell us a little bit about this patient who had metastatic disease, actually initially hormone sensitive? I guess in him it was a little complicated.
So wait, this is not the PARP.
No, I know it's not PARP.
Okay,
just
all right,
to finish out. Yeah, no, just to finish this out.
This man, he was a very gruff man. He's a farmer, didn't like the medical profession at all. He had no respect for his primary care doctor who was managing his diabetes and his hypertension. And when he had his primary treatment for prostate cancer with radiation and that followed by cryotherapy, he became totally an incontinent of urine. And so he came to us when he developed metastatic disease, and he was very angry at how his cancer had been treated, and very angry in general that somebody had told him, well, if you have metastatic disease, it's a death sentence. And so he thought he had a very short time to live. What he basically ended up doing was we put him on hormonal therapy. He responded to it. So he was castrate sensitive. At the time, there was no way he was going to let us give him chemotherapy because that was a standard. But he was like, no, I'm not coming in every 3 weeks. I'm coming as little as I can. And he basically said to me, ma'am, I will not come during haying season. That's it. So that's it. When he developed...
Which season?
Haying.
Haying. He was a farmer.
Haying, okay.
Hay, yeah. And he had to like be doing bales
Us
of hay.
Us people in Miami, we don't know about haying.
Yeah. Right. So in any case, when his bone mets returned, we needed to add therapy. And in his case, because, as he was a pretty brittle diabetic, he also had some episodes of vertigo and dizziness. which made him lose work. So we kind of decided to go with apalutamide instead of enzalutamide because at the time, darolutamide was not approved in this setting, and the apalutamide was going to have less chance of CNS effects. And as it is, you know, he's done okay on it. I did need to dose reduce him. You talk about anecdotal things. I mean, he developed taste changes, which I didn't necessarily anticipate, but that interfered with his eating. He lost weight. He was more tired with his long days. So when we dose reduced him, that got better, and he was able to stay on the therapy. But I think a key thing about you know, this kind of coming up during the pandemic and whichever, and people not wanting to come to office appointments, we use telehealth a lot more now, so to monitor people who are not going to necessarily tell us symptoms if they're not in front of us. And we also, you know, I had to let him know, look, we need to monitor your labs. You have to go get your lab. I'll be happy to go over with the phone, go over them with you on the phone, but, you know, we have to make sure that you're doing okay. He's always a challenge, though.
Yeah, I'm curious how you feel about when you see his name on the clinic list. Are you like, oh?
Oh, I'm quite used to it. I mean,
I'm curious how your relationship with him has developed. Do you feel like he trusts you?
I do. I mean, basically, when he came to us, he didn't trust anybody, and, you know, we kind of told him, we were honest with him and direct. You know, yes, we can't say we're going to cure you, but we have a lot of tools we can use to try and, you know, extend your life. And as he saw that that was working, and I would be just as tough with him as he was with me. So, you know, he would come in and I'd go over his meds and I'd say, how much insulin are you taking? And he was like, well, I'm supposed to do this, but I don't. You know, I'm doing what I want. And so I would just like throw it right back at him. For a while before his disease recurred, I was like, look, your diabetes and hypertension are going to be much more likely to kill you than your prostate cancer. So you got to pay attention to that. So like he'll say, I respect you, ma'am, I like you. I don't like him, I like you. But I'm going to try and do what you say.
You know, I talked earlier about the fact how much people value you. And you can imagine how much, really deep down, how much this man values you and what you've been able to do for him. It's really awesome. All right, well, let's talk about the next big development in prostate cancer, the use of PARP inhibitors. Again, we've already talked about it in breast cancer and a lot in ovarian cancer yesterday. And it looks like a lot of the things that we've learned from these two diseases, particularly ovary, are applying in breast cancer. We're going to present a couple of patients who actually received PARP inhibitors. But Sandy, can you kind of paint a little bit of a picture about how PARP inhibitors work? How you identify patients to get PARP inhibitors? Basically, again, we get into the theme of tumor markers and looking inside the tumor, and in this case, looking for germline mutations. So how do PARP inhibitors work, and where do they work the best?
Yeah, I mean, I think it was really revolutionary how PARP came into prostate cancer. We have thought of these mutations being more common in breast cancer, but really after a decade of searching, it's become very clear that prostate cancer, patients with prostate cancer harbor these mutations either in their germline, so every single cell in their body, or the tumor itself has its own DNA, which can harbor these mutations. So between germline and these tumor, overall, there's about 25%, so 1 in 5 men can harbor these mutations. Why is this important? Clearly, we have medications that we can give these patients when we identify them. So for germline patients, let me back off a little bit, that the incidence of this is much higher in patients with metastatic disease compared to localized disease. But it's really important to test for them because there are implications for the patient himself. We now know that BRCA mutation is both prognostic and predictive. Patients who harbor this may have a worse outcome. We also know that there are implications for their children, for their siblings, including women. So if they were to have girls, they have an increased risk of BRCA-associated cancers. Even the patient themselves, if you were to have a BRCA2 mutation with prostate cancer, they may be at risk for pancreatic cancer or melanoma. So clearly understanding this and knowing this is a key. So guidelines recommend germline testing for patients with high-risk localized disease. For patients with de novo metastatic disease, who come in for the first time, because they have a worse outcome, we want to know, did the BRCA contribute to it? And then we want to do it for all patients with metastatic disease, because we now have 2 FDA-approved drugs, one olaparib, which is a broad indication for all patients with HRR mutation. So BRCA is not the only mutation. There are about 15 others that include in this category that we call homologous repair defect pathway. Though it appears that these drugs have the highest impact on patients with BRCA mutation. So we have 2 FDA-approved drugs, olaparib, and the second one called rucaparib. Both of these drugs currently approved as monotherapy for patients who have metastatic castrate-resistant disease who harbor one of these mutations.
Until yesterday, when the FDA actually approved the use of olaparib in combination with abiraterone, and we'll talk a little bit about that. But again, now you come in on Monday and now it's approved. We're going to see how people respond to it. And we'll talk about the approval too, because it was a little controversial. Before we get into that, Neeraj, can you talk a little bit more about how PARP inhibitors work and also what kinds of tolerability issues are involved?
Yeah, this is a pretty wide spectrum question about PARP inhibitor tolerability and how they work. So I'll probably take a minute. So first of all of us have these mutations happening on a daily basis in millions of our cells. And there is an enzyme, PARP, poly-ADP ribose polymerase, which help our DNA repair those breaks or mutations. Now, DNA repair mutations, so our DNA mutations are helped being repaired by some of the genes known as DNA repair genes. And if those genes are not working very well, then these cells tend to accumulate a lot more breaks on a daily basis than they were doing without these mutations. So these cells, which have these deficiency or defects in the DNA repair genes, they are highly reliant on PARP, poly-ADP ribose polymerase enzyme, because PARP has to work 10 times, I'm just making it up, 10 times at a higher level to compensate for so many breaks which are coming up. Now, at this point of time, as Sandy said, if you inhibit this PARP enzyme with these drugs like olaparib or rucaparib, then these tumors cannot really handle these double assault because of the inherent deficiency of DNA repair genes, and now we are making them deficient in PARP. Now, the second step, which you mentioned, Neil, yesterday, we saw favorable recommendation by ODAC for a subset of patients of the combination of abiraterone and olaparib, and this is based on the theory or some preclinical rationale that when you stop the cells or assault the cells by using these hormonal therapies, these cells have this BRCA-ness phenotype. They become more reliant on this PARP enzyme to be able to compensate for the assault by these novel hormonal therapies, and they are more reliant on PARP. And then at the same time, when we use PARP inhibitor, these cells become very sensitive to killing by abiraterone. And this can be extrapolated to even those cells which do not have DNA repair defects. And the data is there, more data are coming regarding effectiveness of this combination in those patients who do not have DNA repair deficiency in these cells, and you can use these two drugs and it still show enhanced death or improved outcomes. Now, coming to the side effects, the most common side effects, I think the class effect is myelosuppression. Anemia, neutropenia, thrombocytopenia, which vary from one PARP inhibitor to another PARP inhibitor. Some PARP inhibitors have more thrombocytopenia, some have more anemia. Another class effect is nausea and vomiting and GI side effects. So olaparib may have more diarrhea or nausea and vomiting than rucaparib or than talazoparib, but then rucaparib has some more side effects, or talazoparib may have more anemia but less GI side effects. But I think these are the overall side effects which are pretty easy to manage in the clinical practice by either dose reduction or by using anti-nausea medicines.
So we'll see what the nurses think about how easy it is to manage those side effects. But just to clarify, though, the study that was presented now a year ago, and now the FDA acted on it yesterday, moved the PARP inhibitors up. So when you're using, in this case it was abiraterone, but we talked about the anti-androgen. But the idea before that, it was you use PARP afterwards. What they did in this new study is they moved it up with the hormones, and they saw a benefit. But they saw a greater benefit, as you would guess, as we were talking yesterday, same exact thing in ovarian cancer. If you have a patient who has a BRCA, germline, or somatic mutation, they will respond the best. If they don't have anything, you do still see benefit, but not as much benefit. I guess the thing that, again, we just found out yesterday that kind of got the oncologists a little bit interested, shall we say, is even though the overall trial was positive for everybody, when you looked, and we've talked about this in a number of situations this past week, when you look in the subsets, you saw again that the people who didn't have BRCA didn't do as well. And Sandy, it turns out that the FDA approved it just in the patients who had BRCA and similar mutations. They didn't approve it if they didn't. So they took the choice away from the physicians. How do you think people are going to respond?
I think this is not uncommon in clinical practice. There is, the data is there. The FDA approves something. Clinicians sitting in front of the patient make a choice. For instance, if I have, what we know about these drugs for sure, while it was broadly approved, there is no question that the patient with BRCA mutation has the highest benefit. So I think as physicians, for sure, we should be offering that to patients with BRCA mutation. That would be, it would be wrong if we don't test and if we don't offer, because here is a drug that's adding a lot of value for them. What about those patients who don't have BRCA mutation? Up till now, there was a broad approval, but I think if you have an alternate, that's better. For instance, if I see somebody in clinic who has, let's say, an ATM or some other mutation within that class, and if the patient has a more effective drug, let's say, such as the lutetium, the radioligand, which we are going to be talking about, I would probably offer that patient that as opposed to a PARP inhibitor. So I think we have choices. We pick based on what we know about the data, about the patient in front of us, what the alternates are, and I think that's how we pick our treatment choices.
In a way, it's like we were talking the other day in lung cancer that adjuvant use of immunotherapy is only approved in PD-1 positive patients. Now, the whole trial was positive, but again, the FDA picked out the people who did the best to make the approval. So, it's controversial, but also interesting. I think the most important thing is if you have a patient in your clinic who has metastatic prostate cancer, just like with breast cancer, what's their ER and HER2? You got to know. You can't even think about it unless you have ER and HER2. Well, if you have metastatic prostate cancer and you have germline testing or somatic testing looking for BRCA and other mutations, they have to have it because these are very valuable therapies. All right, let's, before we go on to the next topic, radioligands, another really exciting development. Let's hear a little bit about how PARP inhibitors play out in practice. And Kathy, you have a 69-year-old man with metastatic disease, germline BRCA, which of course brings up the issue of the family. Can you talk a little bit about this man?
Absolutely. So he's a 69-year-old author. He and his partner are not having children, so that was not an issue for them. He was BRCA1 positive, and a good option for him after multiple lines of therapy was olaparib. He did not experience anemia, which is what we typically expect, but he did get that kind of constellation of symptoms, GI symptoms, like nausea, vomiting, and appetite. This is often not a side effect group of that prostate cancer patients have really experienced to this degree. So I find this is an area of we need to jump in and see what are we doing for it, nutrition consult, let's make sure that we kind of nip this quickly before it becomes a problem. I would add one more comment. As you can see, the complexity of these germline mutations, somatic mutations, and treatments, if you're confused by this, as I think most of us are, I would suggest you watch this program again. They did such an amazing job of explaining that. Take that you just heard and turn it into a 1 or 2 minute, maybe 1 minute in these days of no time in healthcare, and see if you can develop a script on how to explain to a patient what a mutation is and means. I like to use, with men's health, I like to use tools and toolbox analogies, but if you work in women's health, same thing, that this is a really important concept that we as nurses need to really grasp and explain.
I didn't tell you about our idea for TikTok, short form video
Oh,
in
no.
oncology. By next year, when we come back to Washington next year, we'll tell you about TikTok, hopefully. But in any event, incidentally, do you agree with Neeraj's assessment that in general, PARP inhibitors are well tolerated? Really?
Yes.
Interesting. Okay, because we always focus on what could happen, but it's reassuring to know not that common. So Susan, another patient, a 79-year-old man. Now this mutation he had was CHEK2. Sandy, you were talking about other mutations. Is CHEK2 something that responds to PARP inhibitors?
I mean, in general, the trials had BRCA is the most common in prostate cancer. So CHEK2 and all of these other mutations, the numbers are so small. So in a large trial that includes all of these patients, parsing out individual mutations can become a little challenging, but there are anecdotal reports of patients responding to PARP inhibitors. The attractiveness is that it's an oral tablet. Again, it's not as harsh as chemotherapy. So I think if there is a patient who has that and has no other alternates, it's very reasonable to consider this.
So Neeraj, Kathy was praising your ability to summarize things. So tell me in 30 seconds, what we know about 2 other PARP inhibitors. So one is niraparib. We saw that last year at the same time as the olaparib trial was presented. Again, yesterday we talked about niraparib in ovarian cancer. It seems to have the same benefit as olaparib, at least in the germline patients. And when you get into the other patients, you maybe see some differences. And then talazoparib, another PARP inhibitor, is approved in breast cancer. We were talking about that the other night. You just presented, just a couple months ago, a study very similar to the olaparib study, actually. Very similar findings where you saw benefit not just in BRCA, but the other patients. So we're going to have to sort that out. The FDA is going to sort that out. Any comments about what we know about niraparib and also talazoparib, Neeraj?
From the efficacy perspective or toxicity perspective?
Efficacy. And also based on, the genomic status.
Yes. So niraparib was combined with abiraterone in Magnitude trial, which was designed in a way that they upfront decided that they are going to compare this combination of abiraterone with niraparib versus abiraterone in patients who are positive or negative for these mutations. So they were very clear from the upfront that this is negative cohort and this is positive cohort. They stopped enrollment on the negative cohort after 200 patients were enrolled, after concluding that the combination of abiraterone with niraparib is not effective compared to abiraterone. And in the positive cohort, they showed benefit in terms of radiographic progression-free survival, and then the mature data was presented in GU ASCO, where they showed more benefit in BRCA1 and BRCA2 subgroups.
There's also a way you can measure for hormone, for HR, proficiency or deficiency. And so you can get a score what about those patients who had the high, score?
Yeah, so I wish we did that in prostate cancer trials. In prostate cancer trials, we are still looking at mutations, unlike ovarian cancer.
So you saw benefit with niraparib in those with mutations, but not without.
Exactly. In the PROPEL trial, Neil, which was discussed by ODAC yesterday, they said we are going to take all-comer population and we'll go back and see who had mutations, who did not have mutations. So retrospective analysis of mutations, which are not particularly liked by the panel yesterday. And then TALA-PRO-2 trial, which I had the opportunity to present, decided that we are going to prospectively assess who has mutations and who do not have mutations. And we are going to stratify the trial by presence or absence of mutations. And then we will also look at those patients as a separate cohort of the trial who have mutations. And so far, what we have presented so far is that talazoparib plus enzalutamide combinations seem to be effective and more efficacious than enzalutamide alone in patients regardless of whether they had mutations or not. But as Sandy said, the degree of benefit is obviously more in the patients who have mutations than who do not have mutations.
And actually, yesterday we talked about in ovarian cancer, actually niraparib had a greater benefit on patients without mutations than olaparib. And in niraparib, that's one of the places it's used in ovarian cancer. So, we spent a couple hours in programs just talking about PARP inhibitors. We're just kind of like trying to introduce it to you. Let's just finish out with this 79-year-old man. What happened with him, Susan, and in particular, what happened when he got the olaparib?
Well, in his case, this was like kind of his last-ditch therapy. He had been through multiple years of abiraterone enzalutamide. He had just finished 10 cycles of docetaxel, and he's got a lot of comorbidities in terms of he's got a nephrostomy tube and a ureteral stent on the other side. He has hypertension, he's on Plavix, he sometimes has hematuria. So, and he's so tough. Like, he got through 10 cycles of docetaxel where I was offering to him, we can do less. He's so tough that he wouldn't let his wife call unless he's like on the ground, that kind of thing. So he ended up in the hospital with neutropenic fever when he had docetaxel. So when we switched him to olaparib, we were at a place where he was tired, and we were saying, we have an option of trying this, or we probably could do palliative care in hospice. And he definitely wanted to be treated, so we started it. The difference for him is that I had to make sure he knew that this was their pills, but they are like chemotherapy, and that we still need to monitor his counts. And even if he's not going to come in every 3 weeks, I needed to initially check his labs fairly frequently so I could make sure he wasn't becoming more anemic or what have you. So when I set up phone visits with them, I say them because his wife had to participate also, so that I could get the true story. But he became fairly fatigued within a couple of weeks, and like he wouldn't get out of the chair to do his calisthenics. That was his fatigue. So I dose reduced him, and he did well. And he's responding to it, and he's kind of holding his own. So that's good.
Sounds good. All right, let's finish out talking about radioligand therapy, a very interesting story. Sandy, can you talk a little bit about what a radioligand is, what lutetium is, and kind of how right now we'd like to use it? It seems there's a shortage of it, unfortunately, but hopefully that'll get resolved. But what is radioligand therapy, Sandy?
Sure. So we know that tumor cells, prostate cancer cells, express a protein on their surface called PSMA. It's called prostate-specific membrane antigen. So the breakthrough really came when we were able to target this PSMA with an antibody. So you can now connect this with the protein, and to the other end is a source of radiation, a beta-emitting radiation called lutetium attached to it. So I tell my patients that we give this as a drug. When it goes intravenous, it goes around looking for where there is PSMA, and once it finds it, it's able to release the radiation into the cell. So with this, it's like we do the PSMA PET scan, which is similar to the regular PET scan, but that's FDG, which is glucose, whereas the PSMA PET scan specifically identifies tumors that express PSMA, and then once they are PSMA positive scan, they would be a candidate for this therapy, which essentially releases radiation to the tumor cells.
What do you know about the efficacy of this, Sandy, and the side effects?
So this was really tested in the most advanced patient population. So it was a trial called the Vision trial, where they took patients with metastatic CRPC. These patients had received hormonal therapy, the novel hormonal therapy that we just discussed. They have received chemotherapy. In fact, 50% of them had received both docetaxel and cabazitaxel. So you can imagine that this is really a highly refractory patient population. So they were randomized to 6 cycles of this drug versus best supportive care. And in the best supportive care arm, they were allowed to get hormonal therapy, steroids. So that was the comparator arm. And the trial did demonstrate that the patients who got this lutetium had an improvement in longevity. They had a more than 50% drop in the PSA. Their symptoms got better. There was improvement radiographically in the liver and no further progression of bone disease. So really, a change in our therapy and a new drug for our patients with metastatic CRPC. Like all drugs, that's where it's approved. We know that there was a press release stating that this drug was effective in patients pre-chemotherapy as well. We haven't seen the data, but like all in oncology, as it works in more advanced disease, we see it moving to earlier lines of therapy, but the current approval is in patient with refractory disease.
So right now, Neeraj, can you comment on the shortage of this agent right now, when we think that's going to end? And also in terms of toxicity, do you see any myelosuppression? I've heard discussion about dry mouth. Do you see that?
Dry mouth is a common problem because PSMA is also expressed by the salivary glands. And otherwise is a well-tolerated drug. When you talk about the patient population, which have gone through multiple chemotherapy regimens, they don't find this drug to be difficult to tolerate. And the scarcity issue is a big deal right now. The patients, we are writing prescriptions, and patients are waiting for months to get the drug. Even after you are able to start the patient on the drug, but then sometimes they're waiting for the 3rd cycle after receiving 2 cycles. And 1 cycle or 1 dose is given every 6 weeks. So you are able to give first 2 doses, and then we are waiting for like the 3rd dose, which may not arrive for next 4 or 5 months. So I think those are the real issues, but I heard that with the new operations, I heard in New Jersey. They are able to resume the supply of this drug. So I think this is a very good option for our patients in that setting who have already progressed on chemotherapy drugs.
Well, let's finish out hearing about Kathy's 62-year-old man who actually is waiting to get lutetium. And maybe you can also talk about your experience with lutetium, Kathy, particularly in terms of how people tolerate it.
Absolutely. Yeah, when you hear how this drug works, I don't know if you were a prostate cancer patient or a loved one of a prostate cancer patient, you can imagine the hope that these families had for this drug at a certain time. So you're right, it's been a very difficult time. I've been the holder of the Pluvicto spreadsheet in my institution.
Oh, my.
And the ethics and the drama has been unprecedented. I've not had this experience before. Guys heard about it early and just expected for it to be there for them. So this is a 62-year-old gentleman, an Armenian gentleman. We have a very large Armenian population around Los Angeles. And he presented with de novo metastatic prostate cancer about 3 or 4 years back and has had really aggressive treatments, chemotherapies and oral agents, as well as a phase 1 clinical trial, a first in human bispecific antibody trial targeting STEAP1. So he's really been through the ringer and wanted to be treated very aggressively. He's an actively working attorney. So we were, and an active member of the prostate support group I work with. So he had to wait months. I would say we had to kind of bridge him with cabazitaxel. He had a pretty bad reaction to docetaxel, so we were hesitant to give him other chemotherapy, a lot of fluid retention, and made him fairly incapacitated for certain amounts of time. But we had to do it because that's all we had. So he actually has gotten his first dose of lutetium.
Oh, awesome.
Oh, good.
About 3 or 4 weeks ago, which is yay. He needed a blood transfusion. He bottomed out after he had had some pancytopenias with his chemotherapy, so he came back on his week 2 kind of check-in, and he was in the high 6s for hemoglobin. So that was a little difficult to manage. And some of these guys, you do have to really kind of keep them going with transfusions. His issue was, these guys become radioactive and need to go on radiation precautions for about 3 days, 6 feet apart from everyone. And then if you have a pregnant woman or young children in the home, you have to be 6 feet away for a week or more. So he happens to live with an extended family. He has children, and the love of his life is a little granddaughter. And he had to make plans for how he was going to do that. How can you isolate from your grandchildren who you live with? So there have been some very interesting kind of challenges with that, which is different for us in prostate cancer. We have a gentleman just got nephrostomy tubes, and we've been in the drama of, can someone manage nephrostomy tubes at home with radioactive urine?
Right,
So
exactly.
very interesting stuff.
It's been an incredible pleasure and honor to work with you this week. Thank you so much for coming here today. Faculty, thank you for attending. Have a good day.